Hello everyone. So today we are here to just how to examine the abdomen or the GIT system. In GIT system, basically we have to see the abdomen, and again in four: inspection, palpation, percussion, and the auscultation. So we'll start from the inspection. How we should inspect the abdomen. So first, this is our subject. We'll ask, take the consent regarding the examination. बाबूजी हम आपका एग्जामिनेशन करेंगे, उसके लिए आपको अपने कपड़े को यहाँ से यहाँ तक करना. So for proper inspection, we have to ask the patient to expose from the jiffy sternum to the pubic symphysis. थोड़ा सा. So after exposing the part, then in inspection, first of all there is a shape of abdomen. The normal shape of abdomen is flat shaped. What is flat shaped abdomen? In flat shaped abdomen, the chest is in align with the abdomen. So you can see that it is a flat chest. So it is a normal shape of abdomen. What are other shape of abdomen? There may be a scaphoid abdomen. And scaphoid abdomen, patient may be a malnourished, patient may be a malignancy, known case of any malignancy. Third one is the ovoid or the globular or the distended abdomen. What are the causes of distended abdomen? There are, you can for your ease you can learn that there is a 6F for the globular or the distended abdomen. What are the 6F? One is your fat. If obesity is there, then excessive fluid in the cavity, that is ascites. Flatus, excessive gas in the large intestine. Then feces, if patient is constipated, then you may have a globular or ovoid distended abdomen. And fetus, in pregnant female there is a distended abdomen. And the last one is, if the urinary bladder is full, then also you may have a distended shape of abdomen. Second is the abdominal muscle. If mass is there, then also it may be a distended. Now come to the next. In inspection, after the shape of abdomen, see the umbilicus. In umbilicus, generally umbilicus is centrally inverted or slightly retracted. So in my subject you can see that this is inverted and slightly retracted. What other things can be of in umbilicus? There may be a everted, or there may be a distended in one side. There may be a transverse or umbilicus, or you may call it as a smiling umbilicus. Then next in inspection is the abdominal movement. We have to see the abdominal movement, whether there is abdominal movement is present or not. In sometimes if patient is having a peritonitis, in case of peritonitis there is a silent abdomen, there will be no movement. If there is a diaphragmatic hernia, then also there is a reverse abdominal movement you may have. Next, the dilated veins. We have to see the IVC obstruction, or we have to see the porta systemic obstruction. If portal systemic obstruction, there may be a caput medusa you may find in inspection. After the veins, see for the visible pulsation. You may see a visible pulsation of aortic dissection or aortic pulsation. You may have an aortic aneurysm that you can see at the epigastric region. Next, after the pulsation is the visible peristalsis. What is visible peristalsis? You may see the peristaltic movements in the abdomen. They may seen in either pyloric obstruction, there may be a distal colonic obstruction, there may be a distal small bowel obstruction, in which you may see the step ladder pattern peristalsis in abdomen. After the peristalsis, see the surface or skin of the abdomen. Normally the smooth shiny skin, you may find a wrinkled skin, you may find a stretch marks or stria you may find in a pregnant female, any scar mark for previous surgery, or and you may, if scar is there, then you have to tell about the location, you have to tell about the size, color, or scar is healed or not. Last, see for any pigmentation or linea nigra, we used to call it as a. So, and last one in inspection is the hernial site. You have to see the epigastrium, you have to see the umbilicus, you have to see the inguinal and the femoral region for any hernial sites. Before palpation, we should know where we have to palpate, or the from where we have to start. Routinely, this abdomen is divided into the 9 regions. And what are the 9 regions? They are basically 2 transverse line and the 2 from above downward lines. From mid clavicular to the anterior superior iliac spine, and the 2 transverse line. So this is divided into 9 total regions. This one is the right hypochondrium, this one is the left hypochondrium, and the this transverse is between the your first costal margin from here to here, and the second one is between the tubercles of the iliac crest. So it is divided into 9, and this mid clavicular line, 2 lines from here, this is one here. So this will be the right hypochondrium, this will be the epigastric region, this is the left hypochondrium, and this is the lumbar region, left, right lumbar, and this is the umbilical area. And from here downwards, there is a right iliac region, left iliac region, and this is the hypogastrium. So these are the 9 quadrants, 9 regions where we have to palpate, or we have to inspect, or we have to percuss according to these 9 regions. Now come to the palpation. Palpation is of 2 types. One is the superficial palpation, another one is the deep palpation. In superficial palpation, we generally start from the left iliac fossa, and then we goes to this like all anti-clockwise to palpate the whole superficial region of the abdomen. Superficial palpation is being basically done to just see the temperature, then is there any tenderness in any region, or is there any guarding or rigidity present. One word about the guarding, that guarding is basically voluntary. Once when you are touching the patient will voluntarily contract the abdominal muscles, and then you will feel a guarding. And what is rigidity? Rigidity basically develops in any inflamed area, and this is involuntary muscle movements are there, and it is in localized part, while guarding it is generalized. Second thing is the deep palpation. That is a very important topic regarding the abdomen. We have to palpate 3 organs mainly: the liver, kidney, and the spleen. And in superficial, we started from the left iliac fossa to this anticlockwise, but for in deep palpation, we start from the right iliac fossa. So now we'll palpate one by one all organs. So for palpation of liver, we have to palpate from the right iliac fossa towards the upper side. So you are starting the palpation. Always ask patient to relax. बाबूजी ये पाँव मोड़ लीजिए आपके दोनों, ये वाला, ये वाला. So we have to relax the abdominal muscles for the palpation. Now we start with the liver palpation. Start from the right iliac fossa. We have to go upwards. बाबूजी यहाँ पेट. We have to palpate in your deep inspiration or the expiration. We will go from above downwards, downwards to above, and then ask patient to take the deep breath. बाबूजी सांस लेते रहो, and we have to ask patient to move his head from one side. इधर move कर लो बाबूजी. So this will be the palpation. We have to use these all 3. बाबूजी सांस लो, छोड़ो, सांस लो, छोड़ो, सांस लो, छोड़ो, सांस लो. In my subject, liver is not palpable. So before starting palpation, we have to see the borders of liver. Second is the spleen palpation. Routinely, the liver is not palpable. Once if it is only hepatomegaly is present more than twice or more than 1.5, then only we will able to palpate. Same here in the spleen also. Spleen is palpable once it is a more than 1.5 or twice enlarged in size. Spleen routinely enlarge in the oblique view, so it comes like this. So we start palpation from the right iliac fossa, and we will go there. बाबूजी ढीला छोड़ो, बिल्कुल सांस लो, ढीला छोड़ो, पेट फुलाओ, सांस लो, ढीला छोड़ो. So this will be the spleen palpable. You will palpate the spleen once if it is a splenomegaly is present. Third one is the kidney palpation. Routinely kidneys are palatable. So how we have to palpate the kidneys? We can palpate both the left or right one. For the left one, we have to ask to patient, बाबूजी सीधे इस तरफ लेट जाओ. You have to go again from right iliac fossa to the left this one, and you have to this hand you have to push something like this, and then you have to palpate the kidneys. Same here, बाबूजी इधर मुँह कर लो. My this hand will give a. So if there will be kidneys can be palatable, you have to push from this side and this one. So in percussion, we will start to see the shifting dullness. What is shifting dullness? Shifting dullness is that once there is a fluid accumulate in your peritoneal cavity. So in peritoneal cavity, if fluid is not moderate or severe type, if it is a less than more than 500 and you are not able to grossly find out the ascites, then you may go with the shifting dullness. In shifting dullness, what we used to do, we used to percuss from the right to left or left to right. If बाबूजी मैं आपको भी अंगुली से परकस, and always follow the rules of percussion. We have to use this flexor, this fleximeter, and then routinely in percussion, I forgot to tell you, there is a tympanic knot. Why tympanic knot? Tympanic knot is because there is a hollow viscera, and if there is a fluid is there, then you will find the dull knot. So we have to check whether there is a dull knot present or not. So we will start like this. If fluid is around 500 ml, then you may have a fluid shifting dullness. So start from this side, there will be a dullness, and once you want to check whether, then you have to ask the patient to move that side. बाबूजी उधर हो जाओ. So keep this hand here, and then you will feel the go downwards. The shifting dullness will be changed from here to the another region. So this is the shifting dullness. And fluid thrill is बाबूजी ऐसे सीधे लेट जाओ. When there is a moderate or severe ascites, then you ask patient, बाबूजी अपना हाथ एक हाथ यहाँ रखो, हाँ ऐसे रखो ऐसे. And this is how we have to put your hand. One is here, and you just do like this. If there is a moderate ascites, then fluid thrill you will feel there. So this is the fluid thrill. And last part of abdominal examination is the auscultation. In routinely, there is a intermittent low medium gurgle sounds will be fine in a normal subject, and if there is a subacute intestinal obstruction or any intestinal obstruction, then your sounds will be delayed or will be absent. Usually you may auscult all area in all 9 regions whether the normal bowel sounds are present or not. For bowel sounds, we have to listen for at least 1 to 2 minutes. It's not like that cardiac that you just heard for a 15-second or a 30-second. But here you have to listen for a 1 to 2 minutes. Then you have to keep your diaphragm here, and then you should listen the bowel sounds like that. Apart from bowel sounds, there particular is venous hum. In portosystemic shunt, there may be a at the level of liver or umbilical area, the venous hum may present, or any arterial bruit. Whether you can feel it at a epigastric region or for the renal bruit, you can listen on the abdomen. So this was all about the auscultation of abdomen and abdominal examinations.